Bismillah ar-Rahman ar-Rahim, everyone. Thank you for allowing us to present this case or to present this talk. The talk is a very interesting talk about radiological isolated syndrome. Before talking about radiological isolated syndrome, I have to quote a say from Neil Armstrong, which claims your best quote that reflects your approach. It's one small step for a man, one giant leap for mankind. So why am I mentioning this here? Because radiological isolated syndrome is a very controversial talk. And we are one small step ahead to change a paradigm for management of radiological isolated syndrome. And I will tell you clearly why. So before talking about RIS, so the outlines would be to define what do I mean by RIS or radiological isolated syndrome, the clinical criteria and the updated clinical criteria. We're going to be talking about 5 to 10 years risk for conversion to first onset MS symptom. Then we're going to end up with recent updates on the risk factors and the management of RIS. So let's go through this MRI imaging. If you see this image in a patient who come to you in the clinic without knowing any history, you would, from the first onset or from the first look, you will suspect multiple sclerosis because you have features suggestive of it. You have ovoid, well circumscribed lesions, periventricular lesions, juxtacortical with Dawson's fingers and gadolinium enhancement. So these are very classical features of patients with MS. So what are the criteria for radiological isolated syndrome? So if you have a presence of incidental identified CNS white matter changes, meeting the following criteria. It should be ovoid, well circumscribed, homogeneous foci with or without involvement of corpus callosum, T2 hyperintensities measuring more than 3 millimeter, and fulfilling the Barkov's criteria for dissemination in space, with CNS anomalies consistent with the vascular, not consistent with the vascular pattern. So clinically, there should be no history accounting for remitting, relapsing clinical symptoms. The MRI anomalies should not account for clinical apparent impairment. MRI should not be due to toxic substance. Should exclude leukorrheusis or extensive white matter changes. MRI anomalies not to be better accounted by another disease process. So the updated inclusion criteria should be demonstrating lesions, dissemination in space, by meaning more than one hyperintense lesions, and at least 2 of the following topographies, either in periventricular white matter, cortical, juxtacortical, spinal cord, and infratentorial or infratentorial. So basically, to sum up, if you have no specific symptoms with MRI suggestive of demyelinating disease, this fulfills basically a suspicion of RIS. So what is the incidence of RIS? How often you see it? So in postmortem trials done on 2,500 patients, it was estimated to be 0.2% to 0.08% of population. In a population study in a town in Sweden, which is supposed to be the highest prevalent area for MS, examining 2,250 scans in 1,907 patients, it was estimated to be 0.8 per 100,000. You should be extremely cautious in subject with migraine or chronic headache, patient with seizures and multiple white matter changes, patient with paroxysmal symptoms, psychiatric disturbances or overt cognitive symptoms, you should be very cautious in suspecting or labeling them with RIS. So shifting the gear now to 5 years risk for developing or acute or progressive symptoms. They explored many parameters and they found out that best parameters that predicts development of acute or progressive symptoms or symptom onset of multiple sclerosis is age above 37 and spinal cord involvement. So these two factors are very important factors for developing first onset MS symptoms. So they found out people who have cervical lesions versus those who don't have cervical lesions. The following up, 87% of those who had cervical lesion developed first clinical event versus those who had normal cervical spine lesion developed, 7% of them developed first clinical event. So that's a big difference. Cervical cord or spinal cord lesion is a good indicator for developing first onset clinical event. So shifting the gear now to 10 years follow-up of RIS. You see the curve here that 51% of people develop cumulatively or have cumulative probability of first clinical event. So that's a very big number, and that encourages us to treat such patients. So therefore, we are very animate to clearly identify risk for having first clinical symptom. And those risks would be for this study in the following 10 years would age again above 37, positive oligoclonal bands, spinal cord lesions again, and infiltratory lesion. Those will count for developing first clinical event in the next 10 years. So is there other parameters which can identify developing first onset symptoms? Yes, cortical lesion was found to be one of the risk factors that may develop, that may account for developing first onset symptom of multiple sclerosis, specifically in the frontotemporal areas. We find many multiple demyelinating lesions. Is there any specific sign which can account for risk of progressing to MS? Yes, central vein sign. So if you see hypointensity in the lesion, that may predict or they may show you that this patient may develop first onset clinical symptom of MS. Also, hypointense REM or central vein sign. These all are symptoms or findings that may predict or may have risk for developing first onset MS symptom. Also, gray matter loss, specifically thalamic atrophy over the course of few years was found to be a risk parameter for developing first onset MS symptoms. Gray matter loss is more prevalent in RIS, radiological isolated syndrome, than in CIS, clinical isolated syndrome. Cognitive function. Cognitive function was found to be impaired in RIS and was demonstrated by multiple tools such as PASAT, phonemic fluency test, digit symbol subset test, and WISE-R test. Cross-tapping is more of subcortical memory loss rather than cortical one. Means that they have executive function loss, clock drawing problem, Luria test impairment, or go-no-go test impairment. So the overall convergence to MS in the next 5 years turns out to be approximately 1/3 of all people with RIS develop first onset clinical symptoms of MS. The mean time for developing first onset MS symptoms turn out to be approximately 2.5 years. in many studies. So is there any location which predicts, or you say, oh, that location will tell you that this patient will probably develop first onset MS symptom? There is no specific location, but we found out, and the studies found out that numerous periventricular lesions and gadolinium enhancing lesions are the best indicators for increased risk for conversion to MS. Are there other laboratory tests which may indicate risk for developing first onset of clinical MS symptoms? Yes, positive oligoclonal band, positive neurofilament test, and if when people who don't like to do invasive tests, then optical coherent tomography, OCT impairment will predict disease activity in RIS. So to sum up all the risk factors: age above 37, gadolinium enhancing lesions, numerous periventricular lesions, cortical lesions, cerebellar lesions, or cerebellar atrophy was found to be a risk factor to develop first onset MS symptoms as well. Thalamic atrophy, infratentorial lesion, spinal cord lesion, and abnormal lab results. All these factors accumulatively, one of them or multiple of them would account for increasing risk of developing MS or first clinical isolated syndrome. So shifting the gear now to paradigm, do we clearly know what's the management of RIS? Unfortunately, there is no clear guidelines about the outcome if treated early or if we treat it when the symptom starts. But accumulating the studies, that we found out that 19% of people with RIS were started on treatment or by one of or other disease modifying drug. Knowing that you have an increased risk of having first onset clinical isolated syndrome in the next 10 years, it's specifically 50%. If you have dissemination in time with multiple risk factors, which we mentioned before in the past, plus oligoclonal band, it is reasonable for many experts to treat after discussion with patient and family and telling them clearly there is no specific guidelines about it. On the other hand, if you have single MRI with no risk factors, the expert claims that they wouldn't treat, and they would repeat MRI in 6 to 12 months, and you may need to repeat it for 1 to 3 years, and sometimes the expert claim you may need to treat it for up to, you may need to repeat the MRI up to 5 years. They are promising 2 ongoing trials with dimethyl fumarate and teriflunomide in both Europe and United States, and the results are still ongoing, or the results are still not coming yet. Vitamin D, we know, is an independent risk for progression of MS, and there are ongoing trials for treatment of vitamin D for people who are having radiological isolated syndrome. It is reasonable for those who are having radiological isolated syndrome, knowing that the risk that they may convert in the next 1 or 2 years, it is reasonable for many patients to treat them with vitamin D, especially if they have low vitamin D or borderline vitamin D. Hereby, I'm thanking you very much for concluding my talk. As we mentioned, radiological isolated syndrome is a controversial topic. The treatment is still not established, but many people prefer to treat if they have risk factor associated along with dissemination in time, and especially if they have positive oligoclonal band or neurofilament test or impairment of OCT. Thank you very much and have a nice time.